Bleeding. The National EMS Education Standard Competencies for this particular chapter. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Bleeding, recognition and management of bleeding. So the chapter will focus on recognizing bleeding and the different procedures utilized by EMS responders to manage bleeding. Chapter will also focus on the pathophysiology, assessment and management of bleeding. Pathophysiology applies fundamental knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. Introduction. It is important to be able to recognize bleeding and understand how bleeding affects the body. Bleeding can be external or internal. Bleeding can cause weakness, shock, and it can lead to death. Let's review the anatomy and physiology of the cardiovascular system. Cardiovascular system circulates blood to the cells and tissues within the body. It delivers oxygen and nutrients, and it carries away metabolic waste products. It is responsible for supplying and maintaining adequate blood flow. And if the circulatory system is able to exchange nutrients and oxygen and remove waste and carbon dioxide, then the body is able to carry out good perfusion. There are three parts of the cardiovascular system. You have the pump, which is the heart, you have the container, which is the blood vessels, and you have the fluid, which is the blood and plasma. And we will look at each component individually. The heart. The heart needs a rich and well-distributed blood supply. It works as a two-tiered pump or pumps. It has an upper chamber or upper chambers, which are the atrium, and you have the lower chambers, which are the ventricle. The upper chambers are responsible for receiving blood. The lower chambers are responsible for distributing blood. The left ventricle is the largest chamber of the heart because it does the most work. Within the heart and outside of the heart, there are valves. The presence of these valves ensure that there is no backflow of blood in the wrong direction. And when these valves open and close, that's what we're listening to when we listen to a patient's heartbeat. The right side of the heart circulates blood from the body to the lungs. So the right side of the heart is the deoxygenated side or the dirty side, as I would say. The left side of the heart circulates oxygen-rich blood from the lungs to the rest of the body. So the left side of the heart is responsible for receiving and distributing oxygenated blood. So that's the clean side. It is the most muscular of the two pumps because it must pump blood into the aorta and arteries in order to reach all cells of the body. I've already stated this. The left ventricle is the largest chamber of the heart because it does the most work. Now let's look at the blood vessels and the blood. Arteries carry blood away from the heart. A is for away. Arterioles are the smallest arteries in the body. The aorta is the largest. The arterioles, smaller vessels that connect the arteries and capillaries. Capillaries pass among all cells and link to arterioles and venules. Capillaries are the smallest blood vessels within the body, and the capillaries is the connecting point between the smallest artery and the smallest veins. So the capillary is a connection point between the arterioles, which is the smallest arteries in the body, and the venules, which is the smallest veins. So venules, very small, thin wall vessels that empty into the veins. Venules, smallest arteries. Sorry, venules, smallest veins. Vena cava is the largest vein within the body. Veins carry blood from tissues to the heart. So arteries carry blood away from the heart. Veins carry blood towards the heart. Now, the only artery that carries blood directly to the heart is the coronary artery, and that's the artery that supplies the heart muscle with blood, and that is also the artery that will be affected when a patient gets a heart attack. Now, primarily, the arteries carry oxygenated blood, with the exception of the pulmonary arteries. And primarily, the veins carry deoxygenated blood, with the exception of the pulmonary veins. These are important things to note. Oxygen and nutrients pass from the capillaries into the cells, and at the level of the capillaries is only one cell at a time can pass. Waste and carbon dioxide diffuses into the capillaries, and that's the process of respiration. So oxygen and nutrients pass easily from the capillaries into the cells, and waste and carbon dioxide diffuse from the cells into the capillaries. Oxygen and carbon dioxide pass freely between the lungs and the capillaries. Blood contains red blood cells or leukocytes, sorry, erythrocytes. I don't know what I'm saying. So red blood cells or erythrocytes, responsible for the transportation of oxygen to the cells and the carbon dioxide away from the cells to the lungs. The primary role or function of the red blood cell is to facilitate oxygen molecules. And the red blood cell can hold up to 4 oxygen molecules. Once it has 4 oxygen molecules attached, the cell is properly oxygenated. Red blood cells are not able to move on their own, so plasma moves the red blood cells around the body. White blood cells or leukocytes. White blood cells are responsible for fighting infection, and they also have an inflammatory function within the body. So they are responsible for the process of inflammation and fighting infection. Unlike the red blood cells, white blood cells are able to move to anywhere within the body there is an issue. So they move on their own. Platelets are responsible for forming blood clots within the body, and the plasma is the fluid that transports all of these components. Blood clot formation depends on blood stasis, meaning the flow of blood stops or slow down, changes in the blood vessel walls, that's the diameter of the blood vessel, and the blood's ability to clot. When tissues are injured, platelets begin to collect at the site of injury, red blood cells then become sticky and clump together and a clot is formed. It's a lot more complex than that, but we don't need to get any more complicated than that at this level. Now, the autonomic nervous system. The autonomic nervous system monitors the body's needs and it adjusts blood flow, automatically redirects blood away from other organs to the heart, brain, lungs, and kidneys in an emergency. And it adapts to maintain a homeostasis and perfusion. Homeostasis is a state of balance within the body. Perfusion is the exchange of oxygen and nutrients and the removal of waste and carbon dioxide within the body so that the cells within the body can carry out their normal metabolic function. Now, what this slide is saying is that based on our activity or daily activities, our body adjusts for blood flow. So that means when you're lying down or when we are lying down, our blood pressure will not be the same if we're sitting up, standing, walking, or running. The body adjusts the flow of blood based on the activities that we are carrying out to maintain a state of balance and proper perfusion. So that's a review of the circulatory system. Let's look at pathophysiology and perfusion. Perfusion is the circulation of blood within an organ or tissue to meet the cell's need for oxygen, nutrients, and waste removal. Already explained that. Speed of blood flow. It should be fast enough to maintain circulation. It should be slow enough to allow cells to exchange oxygen and nutrients for carbon dioxide and waste. So there has to be a state of balance. Some tissues need a constant supply of blood, while others can survive with very little. So the core organs within the body need a constant supply of blood, or they cannot go without blood flow for a very long time. And when I say core organs, I mean the brain, the lungs, the heart, kidneys. These are core organs. They need a constant supply of blood, or they cannot go without blood flow for a very long time. If there is something that if there is something that compromises the blood flow to these core organs, then the body will make adjustments to ensure that blood flow is still going to these areas within the body. All organs and organ systems depend on adequate perfusion to function properly. Death of an organ system can quickly lead to death of the patient. Emergency care supports adequate perfusion until the patient arrives at the hospital. The heart requires a constant supply of blood. Now let's look at external bleeding. Now, hemorrhage means bleeding. The word hemorrhage means bleeding. External bleeding is visible hemorrhage. The significance of external bleeding. With serious external bleeding, it may be difficult to tell the amount of blood loss. Blood looks different on different surfaces. Estimate the amount of external blood loss. The body will not tolerate a blood loss greater than 20% of its blood of a patient's blood volume. And our blood volume is what? About 5 to 6 liters. So apart from that, If a person loses 500 mils of blood within a short period of time, they will start to show signs of poor perfusion or signs of shock. Now, changes in vital signs may occur with significant blood loss. So when there is significant blood loss, this is going to cause the heart rate to increase, and it's going to cause an increase in respiratory rate. So if there is significant blood loss and the blood pressure falls or starts to drop, or perfusion to the core organs is interrupted, the first thing the body does is constrict the arteries to increase the pulse rate or heart rate. That's the first thing the body does when there is a drop in blood volume. Now, apart from that constriction, the respiratory rate will increase to get more oxygen into the blood. So it's a compensating mechanism. Continuing with the significance of external bleeding, how well people compensate for blood loss is related to how rapidly they bleed. An adult can comfortably donate 1 unit, which is 500 mils of blood over 15 to 20 minutes. If a similar blood loss occurs in a much shorter time, the person may rapidly develop symptoms of hypovolemic shock. That's low volume shock or low volume, which causes a drop in perfusion, low perfusion. Consider age and pre-existing health conditions. So the age of the patient and if they have any medical conditions can also affect how they respond to blood loss. Now, characteristics of external bleeding. Serious conditions with bleeding are usually associated with a significant MOI. The patient has a poor general appearance and is calm. Signs and symptoms of shock would be present. There is significant blood loss. The blood loss is rapid and it's difficult to control, or it might be uncontrolled. Now, arterial bleeding. Arterial bleeding is arterial bleeding pressure causes blood to spurt and makes bleeding difficult to control, typically brighter red and spurts in time with the pulse. So the blood that flows within the arteries is under high pressure, and when the arteries are bleeding, it mimics the contraction of the heart, so it spurts. And this makes this type of bleeding difficult to control. And because the arteries primarily carry oxygenated blood, this arterial bleeding is usually bright red. Venous bleeding. Venous bleeding is dark red. It flows slowly or rapidly depending on the size of the vein. It does not spurt and it is easier to manage. Veins carry blood out towards the heart, so the flow of blood towards the heart is under low pressure. So when the veins are damaged and they start to bleed, it's steady bleeding. Now, depending on which vein is bleeding, it can be significant or it can be insignificant. Because the veins primarily carry deoxygenated blood, the color of venous bleeding is dark red. Now, capillary bleeding. Capillary bleeding, bleeding from damaged capillary vessels. These are tiny vessels. Therefore, this bleeding is going to be slow. It is going to be dark red and it oozes steadily but slowly. So bleeding from capillary vessels is darker and oozes from the wound slowly but steadily. Venous bleeding, as I mentioned previously, is darker than arterial bleeding and flows steadily. Arterial bleeding is characteristically bright red and spurts in time with the pulse. So the most difficult one to control is going to be arterial bleeding. Now, clotting. Bleeding tends to stop rather quickly within about 10 minutes. When skin is broken, blood flows rapidly. The cut end of the vessels begin to narrow, reducing the amount of bleeding. Then a clot forms. Bleeding will not stop if a clot does not form. Now, hemophilia is a bleeding disorder. This patient lacks blood clotting factors, and bleeding may occur spontaneously. All injuries, no matter how trivial, are potentially serious. Patients should be transported immediately. Now let's look at internal bleeding. Can be very serious because it is not easy to detect immediately. Injury or damage to internal organs commonly results in extensive internal bleeding, can cause hypovolemic shock. So your goal as an EMS responder is to pay attention to impact points on your patient and pay attention to cavities within the patient's body, the cranial cavity, spinal cavity, thoracic cavity, abdominal cavity, pelvic cavity. These are spaces that can hold blood. And the larger that cavity or space, the more blood can accumulate there. So the thoracic cavity can hold a significant amount of blood. The abdominal cavity can hold a significant amount of blood. Pay attention to subtle discoloration around the abdomen, around the navel and over the flank. Because of the size of the abdominal cavity, it's like a cup with ice inside that cup. If you pour water inside a cup with ice, you will not see the water at the top until the space between the ice is filled. It's the same principle regarding the abdominal cavity. So when there is bleeding occurring in the abdominal cavity, you will not see any physical signs, any physical deformity of the abdomen until the space between the organs is filled with blood. Then you start to get distension. So when you see a distended abdomen with significant trauma involved, that patient has lost a significant amount of blood in the abdomen. That's a late finding. So look for subtle discoloration and look for referred pain. So did the patient get hit in the right upper quadrant of the abdomen? So was there traumatic force to the right upper quadrant of the abdomen, and the patient is complaining of pain in the right shoulder? That is something to pay attention to. So the patient got hit in the right upper quadrant and they're complaining of pain in the right shoulder. That's a liver injury. Patient got hit in the left upper quadrant and they're complaining of pain in the left shoulder. That's a spleen injury. These are highly vascular organs. They can bleed significantly. So you need to look out for referred pain as well. Now, possible conditions that can cause internal bleeding. They can have a stomach ulcer, which is like a sore. We'll go into more details in that when we cover the specific emergencies associated with that. They can bleed from a lacerated liver. They can bleed from a ruptured spleen. They can bleed from broken bones. Now, high energy MOI. A high energy MOI should increase your index of suspicion for serious unseen injuries. The index of suspicion is what you consider to be the worst possible injury that the patient can get from the mechanism of injury. Internal bleeding is possible whenever the MOI suggests that severe forces affected the body, and that can be blunt trauma or penetrating trauma. Signs of injury, look for your DCAP, BTLS, IC. So D, deformities, C, contusions, A, abrasions, P, punctures, penetrations, paradoxical motion, D, burns, T, tenderness, L, laceration, S, swelling, I, instability, C, crepitation. Look for signs of injury. Now, NOI for internal bleeding, medical conditions that are linked to internal bleeding. Internal bleeding is not always caused by trauma. It can be non-traumatic causes, which include bleeding ulcers, bleeding from a colon, ruptured ectopic pregnancy, aneurysm. Signs and symptoms of internal bleeding. Pain is going to be the most common one, right? So pain is very common. Swelling in the area of bleeding, distension, dyspnea, which is difficulty breathing, tachycardia, heart rate above 100, hypotension, that's a low blood pressure, hematoma is what you would refer to as a coco. It's a bruise, but there is swelling, and the blood vessel that is damaged for an hematoma is usually arterial blood vessel that will bleed very quickly and cause swelling. So that's an hematoma. It's a collection of blood under the skin. I have different types of bruising. Continuing with the signs and symptoms, bleeding from any body opening, hematemesis, which is vomiting up blood. And if a patient vomits up blood, it is coming from the stomach. If a patient coughs up blood, it is coming from the lungs. Hemoptysis is coughing up blood. Hematemesis is vomiting up blood. Vomiting is intestine. Coughing up blood is the lungs. Melena is blood in the stool, and it's digested blood. Pain, tenderness, bruising, guarding, or swelling. Broken ribs. Bruises over the lower part of the chest. Rigid, distended abdomen. These are all signs and symptoms of internal bleeding. Hypoperfusion. So we're still on signs and symptoms of internal bleeding. Can lead to hypoperfusion, which is shock. This is change in the patient's mental status. They will have weakness, faintness, or dizziness on standing. There is changes in their skin color, or they have pallor, which is pale skin. And you will see pale skin before you start to see blue skin or cyanosis. So the skin will get pale. The skin will get pale once the blood vessels start to constrict and redirect blood flow to the core organs of the body. If that is not sufficient, then eventually the skin starts to get blue because the blood becomes deoxygenated. Now, later signs of hypoperfusion or shock would include tachycardia, weakness, fainting or dizziness at rest, thirst, nausea, and vomiting, cold, moist, clammy skin. Still on the later signs of shock or hypoperfusion, shallow, rapid breathing can represent dull eyes, slightly dilated pupils, capillary refill of more than 2 seconds in infants and children, weak, rapid, steady pulse, decreased blood pressure, which is a late sign of shock. So that's a late sign, and it indicates that the patient is decompensating. So once the blood pressure starts to drop, your patient is decompensating. Altered level of consciousness. So we have looked at the anatomy and physiology of the structures involved as it relates to bleeding. We have looked at the pathophysiology, which is the problems. Let's look at the patient assessment approach to dealing with a patient that is bleeding. So start with your scene size up, scene safety. Be alert to potential hazards. In violent incidents, make sure the police are on scene and follow your standard precautions. Identify the mechanism of injury or nature of illness. So determine the NOI or MOI. Consider the need for spinal motion restriction and additional resources. So is the MOI significant, and do you suspect that the mechanism is diffused? If you suspect that the mechanism is diffused, then you should be considering spinal motion restriction, and if necessary, additional resources. Consider environmental factors such as weather. If the environment is too hot for you, it's going to be too hot for the patient. If it's too cold for you, it's going to be too cold for the patient. So any adjustments you're making for yourself as it relates to the environment, consider the same for the patient. Once you have completed your scene size up, the next phase of your assessment is your primary assessment. Do not be distracted from identifying live threats. Focus on live threats. Form a general impression of the patient and the environment. Note important indicators of the patient's condition. Be aware of obvious signs of injury. Determine the gender and age of the patient, and it's really the developmental age, not the exact age at this point. Perform a rapid exam, look for live threats, and treat them as you find them. If the patient has obvious life-threatening external bleeding, address it first, assess skin color, determine the level of consciousness. So if there is life-threatening bleeding present, you have to address that first before you consider anything else. Airway and breathing. Consider the need for spinal stabilization. Ensure a patent airway. Look for adequate breathing. Check for breath sounds. Provide high flow oxygen or assist ventilations with a bag mask device or non-rebreathing mask. Insert an oropharyngeal airway. The patient is unconscious, gag reflex is absent, and there is a ventilation problem. So your airway assessment is going to be you position, you look, listen, and feel. Make sure the airway is clear, look, listen, and feel. That's if your patient is not responding. So if the patient is responding, and your upper airway is patent, you focus on the lower airway. And if you're focusing on the lower airway, you should be looking at ventilation, oxygenation, and respiration. That's where your assessment will be directed towards. You need to check ventilation, oxygenation, and respiration. And to do that, when you're checking the lower airway, you Count the rise and fall of the chest for 30 seconds, multiply it by 2. If the patient has an irregular breathing pattern, you count it for a full minute. So you want the rate of ventilations or the rate of breathing. You need to look at the consistency of the breathing pattern. Is it consistent? Is it regular or irregular? Is the patient using muscles to breathe? And if muscle use is present, is it on inhalation or exhalation? Is the patient in a specific position to maximize breathing? So is it positional? Can you hear abnormal sounds without auscultation and with auscultation? What is the pulse ox on room air? Is there adequate chest rise bilaterally? So when we assess the lower airway, we are assessing rate, rhythm, quality, and depth. Based on those findings, you will be able to determine if your patient has a ventilation problem, oxygenation problem, or respiration problem. So if there is a ventilation problem, you have to breathe for the patient. And if you're thinking about ventilation management, you should be thinking about airway adjuncts. If there is an oxygenation problem, you will either provide supplemental high or low flow. If there is a respiration problem, it means that your patient is going to need more than oxygen. So again, proper assessment. Now, once we have assessed upper and lower airway and we have addressed any issues associated with the upper and lower airway, the next phase of the assessment is circulation. So within the circulation assessment, we're going to assess pulse rate and quality. So it's pulse, rate, rhythm, and strength. When you're checking a pulse, it's rate, rhythm, strength. If the patient is communicating with you, you check the peripheral pulse. If the patient is not communicating with you, then you check the carotid. So if they are talking, radial pulse. If they are not talking, carotid pulse. Remember that. Determine the skin condition. So what is the color of the patient palm? Is it pale? Is it blue? Is it excessively red? And whatever changes you see peripherally, check for these changes centrally. So if is the patient lips blue, is the mucous membrane under the eyelid blue as well? So is the issue central? So if there's peripheral skin color changes, is it central? If it is central, then the brain is being affected. What is the temperature of the skin? Is it cool, clammy? Is it warm and dry? Is it excessively hot? Is there a delay in the capillary refill time? Is it greater than 2 seconds? It should be less than 2 seconds. Control external bleeding, treat for shock. So that's your circulation assessment. Check pulse, rate, rhythm, strength, check skin condition, temperature, hydration, cap refill, color. When checking the pulse rate, count the pulsations for 15 seconds, multiply by 4. You can count the pulsations for 30 seconds, multiply by 2. If the patient has an irregular pulse, you check it for a full minute. That would be your circulation assessment. After you have completed your ABCs, at this point, you should know what your patient's Glasgow Coma Scale reading is. So you should know the patient's GCS. You should know if you need to do a rapid scan or a focus assessment, you should know if it is a load and go patient or a stay and play. Again, after you have completed your ABCs assessment and management, you should know what your patient's GCS is. You should know if you need to do a rapid scan or a focus. You should know if the patient is a load and go or a stay and play patient. And to determine if you need to do a rapid scan on a trauma patient, you will focus on the mechanism of injury. Now, once you suspect a mechanism to be diffused, your patient will require a rapid scan. Once you suspect that a mechanism of injury is diffused, your patient requires a rapid scan and the patient should be fully immobilized on a spine board, or you will follow spinal motion restriction precautions or protocols. If the mechanism is localized, then you will not be required to do a rapid scan. It's ABCs and you focus on the point of injury. For instance, or for example, if I have a patient that fell out of a mango tree 3 times his height, greater than 3 times his height, upon falling, the patient is responsive, but he's complaining of severe pain to his lower back. He's unable to move his legs, which are fractured. He has bilateral fractured legs. This patient has a diffuse mechanism. So my assessment, my primary assessment is assess his LOC, assess and manage airway, assess and manage ventilation, oxygenation, and respiration, assess and manage circulation, think about his GCS, note it, and do a rapid scan on this patient. This patient would need a rapid head-to-toe assessment. And in that rapid head-to-toe, I'm doing decap BTLS, right? So I'm looking for decap BTLS, I should say. And this patient would be placed on a spine board with a C-collar. So that would be the approach. If I had a patient who was coming down some stairs, and while coming down the stairs, the patient twists their knee, so they slip and twist their knee in a bad angle and may have dislocated their knee. This patient has a localized mechanism, so the injury or the mechanism is specific to the knee. So my assessment would be LOC, assess LOC, assess and manage airway, assess and manage ventilation, oxygenation, and respiration, assess and manage circulation, consider and note the patient's GCS, and then I would focus on the injured knee. So my management would then focus on the injured knee. So note the difference. And as an EMT, you are required to determine when to do a rapid scan and when to do a focus. You will be tested on that. So transport decision. Is it a load and go? Is it a stay and play? Any patient in which you cannot stabilize the life threats completely will require rapid transport. So your assessment is XABCs, and that X means exsanguinating hemorrhaging. So for trauma patients, you need to look for signs of life-threatening bleeding. If present, you have to deal with that before you focus on ABCs. So assessment of XABCs and life threats will determine the transport priority once these areas are compromised. So if there's excessive blood loss, if the airway is compromised, if breathing is compromised, whether it's ventilation, oxygenation, or respiration. If circulation is compromised, the patient requires rapid transport. This is not a stay and play patient. Now, signs that imply rapid transport. Tachycardia, that's a heart rate above 100 beats per minute. Tachypnea, that's rapid breathing. Low blood pressure, that indicates a patient that is decompensating. That's a decompensating phase of shock. Weak pulse, clammy skin. All of these findings are associated with shock. Now, after we have completed the primary assessment, the next phase of your assessment would be history taking. So we need to investigate the chief complaint. Look for signs and symptoms of other injuries due to the MOI and or NOI. Note obvious signs of internal bleeding. Assess the entire patient. You will obtain your sample history, and in the signs and symptoms of your sample, you will obtain your OPQRST as necessary. So sample history, ask the patient about blood thinner or blood thinners or thinning medications. If the patient is unresponsive, obtain history from medical alert tags or bystanders. Look for signs and symptoms of shock. Determine the amount of blood loss. And extremities or body parts in a pool of blood will indicate significant blood loss. So if you come and find clothing soaked in blood or the limbs in a pool of blood, the patient is losing a lot of blood. So suspect hypovolemic shock. Now, once you have completed your history taking phase, the next phase of your assessment is your secondary assessment. So assess all areas for DCAP BTLS. And the same DCAP BTLS that you look for in your secondary assessment is the same thing you're looking for in your rapid scan. And it's actually DCAP BTLS IC. Record vital signs. Attach appropriate monitoring devices. And when you do your vital signs at this point, you will compare the findings in your vital signs to what you found or discovered in your primary assessment. And if you have provided any treatment based on your findings in the primary assessment, your vital signs at this point will tell you if your interventions are working for the patient. So you're going to use it to pick up trends. Is the patient trending up or trending down? With a critically injured patient or a short transport time, there may not be time to conduct a secondary assessment, which is more of a detailed systematic head to toe or focused systematic assessment. Once we have completed the secondary assessment, we move to the final phase of the patient assessment, reassessment. Reassess the patient in areas that showed abnormal findings. Signs and symptoms of internal bleeding are often slow to present. Reassess an unstable patient every 5 minutes and a stable patient every 15 minutes, and you constantly monitor your patient. During the reassessment phase, you will also be doing your communication and documentation. And you have different formats that you can use for that. It can be chronological order, it can be the SOAP method, it can be the chart method. Use whichever method your organization is using. So you're going to have to contact the receiving facility to give them a report on the patient. And it is what the patient told you, what you observed based on your assessment findings, what you did based on your observation, how the patient responded, and your method of transportation. Is it emergency transport? So that's the bulk of your report. What did the patient tell you? What did you observe? What you did based on your observation? How the patient responded to your treatment, method of transportation. So in your reassessment, you're going to be looking at your interventions. Is your interventions working? Do you need to make adjustments? Do you need to trend up or trend down as it relates to your interventions? So provide high flow oxygen, control external bleeding, provide treatment for shock, and transport rapidly. Do not delay transport of a patient to complete an assessment. Communication and documentation. Recognize, estimate, and report the amount of blood loss and how rapidly or over what period of time it occurred. Communicate all relevant information to the staff at the receiving hospital. Document all injuries, the care provided, and the patient's response. Emergency medical care for external bleeding. So we have completed the patient assessment approach to a patient who is bleeding, whether it's internal or external. Let's look at the specific emergency medical care for external bleeding. So follow standard precautions. Wear gloves, eye protection, and possibly a mask or gown. Make sure the patient has an open airway and is breathing adequately. Provide high flow oxygen. Control obvious life-threatening bleeding as quickly as possible. Several methods are available to control external bleeding. You have direct, even pressure, and elevation. You can use pressure dressings and or splints. If you have proper training and it's within your protocols, you can apply a tourniquet. And a tourniquet is not applied the way it is done in the movies. So don't think that watching a movie and see a man tie something around their leg or their arm, that's how a tourniquet is applied. It's not applied that way. Don't do it. So you need proper training to apply a tourniquet. And if you don't have proper training, don't do it. You can damage the patient's nerves and you can damage blood vessels if it's not done properly. Hemostatic dressing, this is more utilized in the army at this point, and these are dressings that have chemical components that will encourage the clotting process. They're still doing research to see what is the best type of hemostatic dressing to use, because some of these dressings, when applied, cause the wound to get hot, too hot. Wound packing, you may have to pack some wounds depending on how deep it goes into the soft tissue. Now, direct pressure. This is the most common and effective way to control external bleeding. Pressure stops the flow of blood and permits normal coagulation to occur. Apply pressure with your gloved fingertip or hand over the top of a sterile dressing. Hold uninterrupted pressure for at least 5 minutes. So you may have to hold it for a while. Pressure dressing. Firmly wrap a sterile self-adhering roller bandage around the entire wound. Stretch the band tight enough to control bleeding. Do not remove a dressing until a physician has evaluated the patient. And if you have applied a dressing and blood starts to seep through that dressing, then you need to put another dressing. Right? Same for bandaging. If you're bandaging a wound and blood start to seep through the bandage, put a dressing, continue to bandage. So the dressings go directly on wounds. Bandages hold dressings in place. So the dressing goes on the wound, bandages hold the dressing in place. A tourniquet is useful if the bleeding cannot be managed with direct pressure. So yes, there are situations in which the application of a tourniquet might be warranted. I have definitely had that experience in the field. However, I repeat, if you have not had proper training in how to apply a tourniquet and how to improvise a tourniquet, do not apply it. So yes, if I have a patient with a crush injury, I would definitely consider a tourniquet application. If I have a patient with an amputation, I would definitely consider a tourniquet application, but it must be within my protocols. My medical director would have to sign off on it, and I would have to have proper training. So that's how it works in a first world system. Your medical director signs off on the skill, you go through a training to ensure that you can apply it properly and you can use improvised methods without causing any harm to the patient. Then you can go there and apply a tourniquet. Hemostatic agents. Gauze can be packed into larger wounds when direct pressure is inadequate or application of a tourniquet is not possible. A hemostatic dressing is impregnated with a chemical compound that slows or stops bleeding by promoting clot formation. Tourniquets. Useful if a patient has substantial bleeding from an extremity injury. Several types of commercial tourniquets are available. Junctional tourniquets allow for compression of life-threatening bleeding in areas where standard tourniquet application is not possible. May be indicated for severe hemorrhage at the junction of the torso with the arm and legs. So you have different types of tourniquets. That's all this slide is saying. And you choose a tourniquet based on where the injury is in terms of which one you will use to apply in that area. Splints. Now, ear splints, so soft splints or pressure splints, can control internal or external bleeding associated with severe injury. So an ear splint can be used for a fracture, and this is a fracture that is not deformed. Can only be used for a straight limb. It cannot be used for a fracture that's deformed. Can also put on an ear splint to create compression on a dressing. So ear splints immobilize fractures. They act like pressure dressing. Use only approved clean or disposable valve stems. Pelvic binder, a type of splint that may be indicated for a suspected closed, unstable pelvic fracture. It helps to control internal bleeding. So you can use a pelvic splint. If you don't have a pelvic splint, you can use a blanket or you can use a sheet. And if you discover an unstable pelvis in your rapid head to toe, do not let it go until it is stabilized. So it must be stabilized before you move that patient. That can kill a patient very quickly. Now, all right, connection went down a bit there. Bleeding from the nose, ears, and mouth. Several conditions: skull fractures, facial injuries, sinusitis, infections, use and abuse of nose drops, dried or cracked nasal mucosa, high blood pressure, which is very common. High blood pressure is a common cause of nosebleeds, coagulation disorders, digital trauma, cancer. All of these conditions can cause bleeding from the nose, ears, and mouth. Epistaxis or nosebleed is a common emergency. Occasionally, it can cause enough blood loss to send a patient into shock. Very rarely that will happen though. Can usually be controlled by pinching the nostrils together and allowing the patient to lean forward. And if that doesn't work, you can put an ice pack on the forehead. Usually we wrap it in a paper towel. The ice pack will cause vasoconstriction of the blood vessels in that area, which will help to stop the nosebleed. Do not allow the patient to pinch the nose and lean back. That can cause the blood to end up in the ear passage. Then you have a bigger problem to deal with. Now, bleeding from the nose or ears following a head injury. So a patient may be bleeding from the nose or ears following a head injury. But when you look at the bleeding, it's not just blood alone. It's blood and a clear fluid. If that is what you're seeing, it could indicate a skull fracture. It may be difficult to control, so do not attempt to stop that blood flow. So if you suspect a skull fracture, do not attempt to stop the blood flow, because if you do, you're going to create pressure going back into the skull against the brain. We don't want pressure going against the brain in a head injury, because the brain is going to swell. Loosely cover the bleeding site with a sterile gauze pad. Apply light compression with a dressing. A target or halo-shaped stain may occur on the dressing if blood or drainage contains cerebral spinal fluid, and that's from a skull fracture. So if you're not seeing blood alone, you should suspect a skull fracture. Emergency medical care for internal bleeding usually requires surgery or other hospital procedures. Keep the patient calm, reassured, and as still and quiet as possible. Provide high flow oxygen, maintain body temperature, splint the injured extremity. Can use a ear splint if you have that device available, and it is warranted. And that would bring us to the end of bleeding. So that's the end of this chapter.